I'm Marcelo Calamita. Today, I'd like to share with you some important issues related to restoration design and occlusal equilibration. This is our patient. We can see in an aesthetic evaluation that he has an important issue regarding the relationship of the arch. If you look at his smile, you can see that he has an asymmetrical lip. Asymmetrical lip is important to evaluate because if the patient has asymmetrical lips, the smile can look crooked when the problem is actually on the lips. We can see in the functional evaluation that he has a cross-arch relationship, and you have to correct that. And besides that, he doesn't have any complaints about TMJ signs of pain or any kind of signal, any kind of discomfort, no muscular symptoms, everything works well. In a structural evaluation, you can see a lot of problems. We can see that we have signs of erosion, signs of abrasion, signs of attrition, and some points of abfraction. So we have to protect that after our treatment is finished. We can see in a different view. In a different view, we can see the attrition in an occlusal perspective. We can see erosion. Erosion occurs in the areas that they don't have occlusal contacts. And biological evaluation, you can see that everything looks fine. But in case like that, we have a lot of times that we can get confused because there are so many things to evaluate that you don't know from where to start. So where to begin? We begin from the evaluation of tooth, or we begin from the evaluation of the gum. We have to remember that the teeth are not very good points of reference because teeth wear with time. Teeth can change position, are extracted, and it can cause some tooth migration in the adjacent teeth. So we have to look for the proper references to start the treatment planning. So what are our good references? We have to remember from the dentures classes in our second or third year at university. You have to remember, I'd like to quote some articles that refers to the correct position for starting the treatment plan. We have to remember how to do a proper wax, hem. In this presentation, didactically, I'm showing like a digital wax trim only to introduce the concept that in case like that, we have to know the real starting point. So if you remember the dentures lectures, we will remember that you have to, when you don't have any teeth, you have to set first of all, the position of the anterior teeth, the position of the incisors. And when you have the position, the musculature corrected, aligned, when you have the correct vertical dimension of occlusion, we can start setting the anterior teeth, and from the anterior teeth, all the other teeth. The same thing happens with my patient. If we don't have references, we have to start looking at the face and have to look at the lips. And from that point on, we can start deciding the correct position of the teeth. So in this diagram, we can see we remove the teeth, of course, digitally. We set tentatively the position of the anterior teeth, and from that point on, tentatively, I set the other teeth from the superior arch, reestablishing the occlusal plane. Of course, it must be tested. I just did it on the computer, like a two-dimensional representation of my future wax-up. It will guide the dental technician to do a 3D wax-up, And this 3D wax up will be tested in the mouth, will be tested for function, it will be tested for phonetics, and it will be tested for aesthetics. So this project is according to the patient's face, is according to the patient's physical and emotional features. So for this case, it's a very complex case. He needs an orthodontic orthognathic approach. We need to reposition the superior arch, we need to reposition the inferior arch to reestablish the proper maxillomandibular relationships. So here we can see the preoperatory views, we can see the a simulation of the orthognathic surgery with a software, special software. He underwent orthodontic treatment before the orthognathic surgery with our team member, orthodontist team member Adalberto, and when he was ready, he underwent orthognathic surgery with Marcus Pita, and this is the case. This is the post-op view, 1 month post-op. We can see the difference in his profile. After 2.5 months, he returned to my office for me to start his treatment planning. Here we can see the case. I usually do some drawings. It can help me to evaluate the case. It help the technician and I to treatment plan the correct position of the tooth. How can I increase the incisal length? How can I manage the occlusal plane? And of course, it will be tested. Eventually, it will be tested in the mouth, and from that point, we can develop our treatment plan. So these are the drawings that I do to help us determine the proper smile design. This will guide my technician to do the wax up. We can see in different views, in the buccal view, we can see in the occlusal view, how can we work with that? Here we can determine how much we're going to increase. Of course, this is not definitive. This will be tested in the mouth. This is very important because I initially made some assumptions that I have to increase 2.5 millimeters, but it should be tested in the mouth. So I guided the technician. I initially mount the case in the articulator. Of course, all this complex case must be mounted in at least semi-adjustable articulator with a facial ball. It will help us to determine all the functional part. It will help us to determine not only the functional part, but also the aesthetics when you use properly the facial ball. The case must be mounted. When you alter the vertical dimension of occlusion, you have to mount the case in centric relations. We have some issues about that, but I like to use some kind of front device. You can use a jig, you can use some leaf gauge, you can use front plateau, you can use some device that I like to let the musculature, when the musculature is healthy, the musculature will lead the condyles to the right position. And then, one thing that I think important to remember is nowadays we don't do directly to a full mouth wax up. I think a full mouth wax up looks great, but sometimes you do a lot of work and you lose a lot of references. So what I think important, we begin the treatment from our smile design. So we think we should test the smile design before finishing our wax up. So we are doing only the buccal wax up. This buccal wax up will be tested in the mouth, and once it's tested and once it's approved, and then we're going to develop the full mouth wax up. Let me show you. Here we can see the full mouth wax up. It looks beautiful, but sometimes it's a lot of work. And once it's not approved, once you have to do some alterations, this alteration means that we're going to spend a lot of time, and depending, a lot of times we're going to spend a lot of money redoing the case, redoing the wax up, because it is a lot of work and you need a lot of time to develop that. So this is the full mouth wax up, but it doesn't give us too much reference because it was not tested anymore. It looks nice on the articulated, but it's not tested. If it's not tested and if it's not approved, we don't have, it's not useful so far. So what do? We do first of all the buccal wax up, and that are the reasons that we do the buccal wax up. I orient the technician how much you have to do, and you have to remember that different situation leads to different results. For example, in this situation A, you have to increase just a little. In the situation B, you have to increase more than this, like 2 millimeters, 2.5 millimeters. And then look what happens if you analyze the situation, if you analyze the antagonist. It's very different, because when you have the situation A and you increase just a little, you don't create obstacles in the anterior guidance. But sometimes, depending how much you increase on the incisal edge, you steepen the guidance, and this guidance will be very inclined, and this inclination leads to torsional force, leads to forces on the ceramics that can make that the ceramics don't last too much. So we create a problem depending on how much we are increasing the length. So that's why it's so important for us to test how much you have to increase the length of the centrals, the length of the anteriors, because all the rest of our wax up, all the rest of our treatment will depend on this decision. So the situation A, the situation B, you have to remember this article. I like to quote this article by Weinberg because it shows, of course, this article was made with implants. But we can derive some of their conclusions showing that depending on how much we steepen the guidance, you have an increase in the torque of the tooth. For example, in this article, he showed that for every 10 degrees, you have 27% of torque increase in the tooth abutment. So the same derivation for the inclination of the incisal guidance, we know that if we steepen the guidance, we can have more torsional force on the ceramics. That's why we try to avoid it, and that's why it's so important if you decide that you have the situation B and you have to increase a lot our incisal length, you have also trying to avoid these problems of inclination of the guidance. We have also to increase the vertical. Increasing the vertical, we maintain the inclination of the incisal guidance, which is quite important, especially in these patients who have problems with attrition. If we steepen the guidance for this patient, we can create some obstacles, we can alter the pattern of the envelope of function. Altering the pattern of function leads to non-predictable results. We can create obstacles. The patient wants to be free of these obstacles. It can works like a starting point for him to develop other patterns of parafunction and leads to destruction of our new treatment. So that's important to keep, not to steepen too much our guidance. And doing like this, we raise the vertical, we increase the vertical. Increasing the vertical, we don't have to prep the posteriors. We can take this as advantage, and with this advantage, we can just add material on the posteriors. We can avoid acting like that, endodontic problems. We can avoid tissue destruction, That is very important.